Hello friends, welcome to the recall session for Oral Surgery and Anesthesia for the INI May 2023 exam. It was a very mixed bag exam, and after I saw all the questions, I realized that some were very easy, straightforward questions like the crossbar elevator, like the Ronger forceps. Some looked very easy, but they were very tricky, like the horizontal favorable, unfavorable fracture question. And some were definitely tough. Questions on internal derangement, questions on the surgery, first approach of orthognathic surgery. So all in all, it was a very AIMS or INI level paper with a mixed bag of questions, with a very good mixed bag of questions. And the quality of questions, the framework of questions was also very good. Okay, the English was nice, and the framing of questions, unlike certain questions in prosthodontics where the framing of the question was a little poor, the language of the question was unclear, it was not like that in oral surgery. In oral surgery, most of the questions were clear-cut, direct, except a few questions in internal derangement that were not very clear. But rest, it was usually a clear-cut paper with mixed level of difficulty. And this is for my friends who are doing residency in maxillofacial surgery and are watching this video for their SR entrance exam. Anesthesia is something you have to know. Basics of anesthesia, every surgeon should know, okay? Even if you're not an anesthetist. If you are a surgeon, for a student also, see, there will be no separate anesthesia teaching to you. But even as a surgeon, even as a student of pharmacology, even as a student of general surgery or oral surgery, you are expected to have certain knowledge of the basics of local and general anesthesia. Of course, local anesthesia is taught to you in oral surgery, but general anesthesia is usually not taught, and we try and cover general anesthesia in the live lectures so that you have a basic understanding of the drugs that are used in GA, of the intubation techniques, of the various simple things that are taking place while the patient is under general anesthesia. Okay, so in this segment, we will discuss all the questions that were there in May INICET MDS entrance paper from oral surgery and from anesthesia. Okay. So the first question was, a patient comes to you with a chronic oroantral fistula 1 centimeter in diameter after extraction done 1 month ago. Okay, what would be your immediate treatment plan for this patient? So even if you do not know the treatment for oroantral fistula, or if you know the basics of it, you can just rule out the options and come close to the correct option. Okay, you should know how to rule out options. So let's look at all the options one by one. The first option says splint with treatment of chronic sinusitis if present before surgery. This is making some sense, so I will keep this option in consideration. The second option is excision of fistula and primary airtight closure immediately. This option is also making some sense to me. I will keep this in mind. So why I'm telling you this method is how to rule out options in exam and how to approach towards the correct answer, even if you are not bang sure about the answer. Okay, as an oral surgeon, I know the answer is A. But even if you are not an oral surgeon, of course, you are an applicant or an aspirant for MDS, still how to approach the answer is what I'm trying to tell you here. Distant flap for fistula closure. Distant flap. Now, it's a 1 centimeter fistula. It's a 1 centimeter hole in the alveolus region. Do you think for a 1 centimeter hole, you need to take a distant flap? So, distant flap is something that is away from the site of defect. It's like a radial forearm flap or a temporal flap in the oral region or a free fibula flap or any flap which is harvested away from the site of the defect is a distant flap. And a flap which is harvested from the local sites like a buccal advancement flap or a palatal rotation flap or a buccal fat pad, these are all local flaps. So usually a small defect like an oroantral fistula of 1 centimeter diameter, you can close with local flaps. You do not really need distant flaps. A big defect, a 6 centimeter, 7 centimeter defect, a bony defect, a composite defect of bone plus soft tissues might need a bigger flap like an DCIP flap or a fibula flap, something like that. So I will rule out this option just by seeing a distant flap. Splint indefinitely. That means you're just putting a splint, putting a dhakkan over that fistula, a lid over that fistula forever. I don't think it is a good option to leave an abnormal communication between the oral and the sinus cavities for lifelong when you have surgical treatment options. So splint indefinitely will also be ruled out. Now, the option A and B is what I am confused between. Okay. So always remember, whenever there is a chronic fistula, there is a communication between the oral, the antral or the sinus cavity and the nasal cavity. Because the sinus drains into the inferior meatus, the maxillary sinus drains into the middle meatus of nose, and oral, sinusal and nasal cavities should be separate. Or sinus and nasal cavities can have a communication, but oral and sinus cavities should not be communicating. So whenever there is a long-term communication, the flora of the oral cavity is communicating with the sinus cavity and the nasal cavity. So there can be sinusitis or inflammation in the sinus lining. This inflammation, whenever you try and close a flap or whenever you try and close a defect in an existing inflammation, there is always a chance that the flap can fail because you are doing that flap in an existing area of inflammation. It is always better to control the acuteness or control the inflammation in that region and then do a procedure, especially if it's a chronic procedure, it's not an emergency. Only in 2 emergency situations you proceed for surgery: an emergency or acute appendicectomy, an emergency or acute dentoalveolar abscess. Only in these 2 emergency situations, the acute situations, you perform surgery. In most of the other situations, you first try and control the acuteness or control the inflammation in the site of surgery, and then you proceed for any defect closure. Okay, like for example, even if you're doing a dental implant in a region of a tooth which is having a periapical abscess, you will try and extract that tooth first, let the abscess dry up after extraction of tooth, after curettage, after antibiotics, and only then when the site is clear of all the infection, you will want to place an implant. Otherwise, that implant will also get infected. Similarly, when you are treating a chronic oroantral fistula, it is not an emergency. Because of the communication of the oral and the antral cavities, there is a chance that the sinus lining might have sinusitis. So I will put the patient on sinus regimen. In my morning mentorship sessions of the live and DCP students, many times I have discussed the sinus regimen, okay, which is composed of 5 things, which is antibiotic, anti-inflammatory or analgesic, antihistaminic, a decongestant, and steam or heat. I like to put my patient on a sinus regimen before doing any sinus surgery or a surgery that involves the sinus, because any inflammation or any sinusitis will be covered even post-op. You can continue with the sinus regimen. I just want that whatever inflammation has happened because of the oral communication, that inflammation is slightly controlled or limited so that whatever flap I perform doesn't fail. So that is why I will choose option A over option B. I will choose option B because it is excision of fistula and primary airtight closure immediately. There is a chance that if I do an primary closure is usually not possible in an oroantral fistula. Primary closure is you just cut off the fistula margins and primarily just by the edges of the existing defect. You just raise the edges and you close the fistula. If the fistula is slightly palatal, then to raise a palatal flap just by extension of the flap is slightly difficult. You can do a buccal advancement flap, you can do a buccal fat pad extension, you can do a palatal rotation flap. Primary closure in a 1 centimeter defect can be a little tricky. Okay, so for both of these reasons, I will choose that I put a splint in the patient so that there is discontinuity, there is at least partial discontinuity between the oral and the sinusal cavity, and I treat the chronic sinusitis with the sinus regimen if present before surgery. If the sinusitis, if I feel that there is sinusitis, I will treat it with sinus regimen for 3 to 5 days, and we call the patient after 5 days after taking these things, and then I will perform my surgery. So the best answer for this question is option number A. Coming to the second question. Slightly tricky question, but I'm sure most of you have marked this correctly. A patient comes to you with fracture of the mandible as seen in the image. The patient is a 65-year-old male, is a 65-year-old smoker. What will be your first step in management of this patient? Now, if you watch closely, there is a fracture, yes, but it's not a clear linear fracture. The margins of this fracture are quite irregular. They are lytic margins, they are irregular borders, and to me it looks more like a pathological fracture. Okay, a pathological fracture is a fracture present in an existing pathology. What can that pathology be? That pathology can be a cyst, that pathology can be a tumor, that pathology can be osteomyelitis or any infection, usually osteomyelitis which is in the bone, or that pathology can be a malignant tumor like a squamous cell carcinoma. Okay, so these are the usual findings that we see in the mandible which can cause a pathological fracture in the bone. Okay, can I see a cyst here? No. Can I see a benign or a malignant tumor here? Maybe it is squamous cell carcinoma of the mandible. Because the patient is old, because the patient is a smoker, these are the two signs that I see that it can be a malignancy which is causing these irregular lysis of the bone, and because of the malignancy, there is a pathological fracture of the mandible. So, will I treat the fracture or will I treat the pathology first? Obviously, I will treat the pathology first. So, IMF with wires and evaluate is a treatment of fracture. Open reduction with fixation and fixation with recon plate. This is the answer if there was just a fracture. Okay, if there had been no lysis, no pathology associated, if only it was a linear fracture in an atrophic kind of a mandible, then this would have been the best answer. But it is not the case. Open reduction with mini plates, it cannot be done in such an atrophic situation. So my treatment, immediate treatment will be first rule out or rule in a carcinoma of mandible. So my first treatment will be I will do a biopsy in this fracture. Okay, I will first do a biopsy. I will take a segment of the soft tissue and the bony tissue. I will send it for histopathology, and most probably in this case I will find a squamous cell carcinoma of mandible. Okay, so the correct answer will be biopsy. Coming to the next question. Okay, this is a slightly tricky and difficult one. A patient comes to you after trauma to face with bilateral diplopia and a restriction of movement of the eye. What will be your treatment? Only if you know that a zygomatic fracture will give these findings, you will be able to approach this question. Okay, these findings are those of a zygomatic, not arch, but a zygomatic body fracture. Okay, when the zygoma fractures, okay, so this is the zygoma. We are not talking about the zygomatic arch. We are talking about the body of zygoma. When it fractures, four things can happen. And these are the only four indications of treating a zygoma fracture. First, that can happen with the arch fracture most commonly is reduced mouth opening. Like we do it in Daughtry procedure or Leclerc procedure, the fractured arch comes in front of the condyle, okay, and it restricts the movement of the mandible. So reduced mouth opening is one of the indications to treat a zygomatic arch fracture. Second indication is cosmetics or a facial asymmetry. After trauma, for some time there is swelling also. So once the swelling subsides, you just have to see whether there is gross asymmetry. If it is just a limited fracture which is stable in its position and it is not causing much of soft tissue asymmetry, then you might leave the zygomatic fracture as it is, if there is no facial asymmetry. So if there is a gross facial asymmetry, then it is an indication for treatment of the zygomatic fracture. Third indication is infraorbital nerve paresthesia. If you remember anatomy, the infraorbital foramen is here. So if this is the orbit, just below the floor of the orbit in the infraorbital rim, this is the infraorbital rim, there is a infraorbital foramen from which the infraorbital neurovascular bundle emerges. Okay, so if the fracture is such that it is causing paresthesia to the infraorbital nerve, which will cause numbness in the lateral wall of nose, in the infraorbital region, in the upper lip. If this region has paresthesia which is not improving with time, paresthesia can also be because of the swelling or the pressure of the swelling on the nerve, but it will improve over 1 or 2 days. It will improve with time as the swelling goes away. If this paresthesia is non-resolving, that means the nerve is entrapped in the fracture and you have to release this nerve to correct the paresthesia. That is the third indication for surgical or any treatment of the zygomatic fracture. And the fourth indication is the orbital symptoms. So just like the infraorbital nerve, sometimes the inferior rectus muscle can also be entrapped due to fracture of the orbital floor. So orbit is not just the infraorbital rim. Zygoma also forms a part of the floor of the orbit. We discussed this multiple times in the live class also, when I actually show you the images of the zygoma forming the floor of the orbit. And if the fracture line runs through the floor of the orbit and there is a trap door kind of a fracture that entraps the inferior rectus or the inferior oblique muscle, then it can cause orbital symptoms like diplopia, which means double vision. The patient can have two images of an object, which is called double vision or diplopia. It can cause restriction of movement of the eye. There are various tests to check whether the eye movement is restricted. Clinically also you can check. In the OT also you can check by forceps and other tests. So if these four are present, any of these four is present, only then you will do a zygomatic fracture treatment. Okay? Now look at the smartness of this question. The examiner is asking you, he is giving you only two symptoms. He is giving you only the option of bilateral diplopia and restriction of movement of the eye. That means this fracture is causing only two symptoms. It is causing only the orbital symptoms. That means only the floor is fractured, causing entrapment of the muscle. This is causing diplopia and this is causing restriction of movement of the eye. He is not telling you that there is paresthesia of nerve. He is not telling you there is reduced mouth opening. He is not telling you there is facial asymmetry. The only symptoms the examiner is giving you is eye symptoms, which happens in trapdoor fractures of the zygoma. And the options are orbital floor reconstruction, floor reconstruction with mini plate fixation. Why do we do mini plate fixation? When we have to fix the other parts of the zygoma. Okay, so the zygoma has four processes. So if it is an unstable kind of a fracture where apart from the orbital floor, the other parts also need fixation, then you do a mini plate fixation. Like the temporal process or the maxillary process of zygoma, if that is also unstable or if that has some asymmetry or some kind of a things, then you will do a mini plate fixation there. Or if the floor is normal, then you don't need to do, if there is no eye symptoms and the floor is normal, then you don't need to do an orbital reconstruction. Only just by putting mini plates, you can correct the asymmetry of the face. Since the question is asking only the orbital signs, that means this is a trapdoor kind of a fracture which is not causing any facial asymmetry, which is not causing any nerve paresthesia. It is only causing entrapment of the orbital muscles, which is causing diplopia, which is causing restriction of movement. So, my treatment will only be orbital floor reconstruction, which is the correct answer. Okay. Why do I don't need a mini plate fixation? Because the question is not saying that there is asymmetry or any other problems with the zygoma. Only mini plate fixation will never correct the orbital floor. To reconstruct or to release that muscle from entrapment, I need to dissect that muscle from the entrapment of the bone fracture, and I need to reconstruct my floor. Okay, I can do it with the titanium mesh, I can do it with iliac crest graft, whatever. So only mini plate fixation is wrong, and orbital floor reconstruction with mini plate fixation is not required. This is a better option, and intraoral reduction of zygoma will reduce the zygoma, but it will never correct the entrapment of muscle. Okay, so orbital floor reconstruction is the best answer of this question. I am sure most of you must have found this question a little difficult, but if you understand the concepts of zygoma fracture, the concepts of treatment, you would be able to answer. Coming to the next question. Straightforward CT was given. I have shown a coronal CT here, but in exam it was an axial CT of bilateral TMJ ankylosis. Usually we don't check ankylosis on axial CT. Usually a coronal or a sagittal view is enough. A coronal view very beautifully depicts the abnormal ankylotic mass, the abnormal fusion of the bones, and usually we see it on a coronal or a axial or a sagittal view, but of course you can see it on an axial view. And axial view, that is the transverse view of the face at the joint level, was given in the exam, where bilateral condyle morphology was distorted just like in this image, and the condyles were like this, the glenoid fossa was like this. This is typical image of an ankylosis, okay? And the options were TMJ ankylosis, condylar fracture. So in condylar fracture, usually they will give you a displacement or a dislocation of the condylar segment, something like this. They will give you a CT where there is a condylar neck and a condylar head lying away from it. This was not the case. Normal anatomy, definitely it was not a normal anatomy. And osteoarthritis has an absolutely different picture, where you find osteophytes within the joint and reduced joint space and all those things. And osteoarthritis is very typical, not really asked in the exam. Okay, so it was TMJ ankylosis, it was rather a bilateral TMJ ankylosis which was asked in exam. It was an axial view, not a coronal view. This is a coronal view which is parallel to the coronal suture. Exam, it was an axial or a transverse view, and the question was on bilateral TMJ ankylosis. In our recorded videos, in our live class, we frequently show you these CT images. As a BDS graduate, as an intern or as a post-intern, I understand that it is very difficult to interpret a CT, but very often we are telling you, we are showing you images so that you understand to interpret the CT. You see those images frequently, and we hope that you are able to remember in the exam also. Okay, so the fourth question on oral surgery was about CT of TMJ ankylosis. Which of these is the earliest sign of syncope? Now this is a repeated question. Many times it is asked in an exam and you know the answer, and most of you have marked it correctly. It is pallor. Okay, you never see constriction of pupil. You see dilatation of pupil and bradycardia in the late stages. In the early stages, So syncope usually has early findings and late findings. The early findings are the patient, so there are some symptoms and there are some signs. Symptoms are the things that the patient feels, and signs are the things that you can observe and you can, elicit before the patient actually collapses. So symptoms are like the feeling of warmth. The patient will feel that, blood is pooling into his extremities and he is feeling warm. The patient will perspire. So perspiration is also a sign. But before perspiration, he will feel that warmth in his face. He will have pallor. So first sign is pallor. Yeah, sometimes it is also called ashen grey color, which is very difficult to interpret in a clinical situation, the ashen grey color. But usually we call it pallor, that the patient एकदम सफेद हो गया. Patient एकदम सफेद पड़ गया. इसे एकदम सुन्न पड़ गया. उसके extremities are cold. So you know that he's probably getting into a vasovagal phenomenon. So you start your preventive measures at that step only. Then the patient will have a bad feeling. Another symptom is the bad feeling that the patient will have. He will feel nauseous. He will feel, a fainting kind of a feeling. He will feel heaviness. These kind of bad feelings the patient will start having. Okay, and initially he will have low blood pressure with tachycardia. So, because of anxiety, because of stress, because of the sitting or supine posture, there will always be peripheral pooling of blood whenever a syncope is happening. And the blood pressure will always be low. The body will try to compensate this blood pressure initially by increasing the heart rate. Increasing, he will have tachycardia, he might even have tachypnea. That is fast breathing. The body is trying to compensate. Okay, the mind doesn't know, but the heart is trying to compensate, and the heart is trying to put, make the blood reach to every organ by increasing the heart rate. But because the volume of blood is low, it is not reaching to the heart. The volume is only low. The blood pressure is low. Initially, there will be tachycardia. The body is trying to compensate. In the later stages, it fails in compensation, and later stages there is bradycardia with, of course, hypotension. Then there is dilation of pupil. The patient will find, you will find the patient yawning and doing such things. There can be tachypnea, there can be reduced heart respiratory rate, that the patient will have visual disturbances. Visual disturbances like he will have black signs, like pura kala pad gaya, blackening in front of eyes and all such things. He will have blackening, he will have dizziness, such kind of symptoms, and in the end there will be loss of consciousness. Okay, so these are the things that happen in a syncope. So there are certain things that happen early, and this is all within minutes. Okay, it is not early is happening 1 hour before and late is happening 2 hours later. This is usually happening within minutes of depositing the LA or within minutes of doing extraction. Okay, so you have to recognize, if you recognize it early, you can manage it early. Okay, you can prevent the patient from actually going from a pallor stage to a loss of consciousness stage. Okay, it is usually reversible. 99.9% cases of syncope do not progress into any kind of unconsciousness. They are usually temporary loss of consciousness, and it can be recovered very, very easily in the clinical situation. But if you just recognize this at an early stage, you can prevent this from happening also. That is the purpose of asking this question. So which of the earliest sign of syncope is an important question. That if you realize that the patient has cold extremities, the patient is feeling the warmth, the patient will feel. You will not feel the patient is warm, but the patient will feel warmth. He will feel that the blood is pooling towards his extremities and like that. And usually it is seen in males in humid and warm environment, that is in summer season. Usually it is seen in these situations. Okay, so that was one question on syncope. Another question on syncope, was about management. Okay, a patient on dental chair suddenly becomes unresponsive, but is breathing. Typical of syncope. The patient will never cease breathing. It is not a respiratory arrest or a cardiac arrest. It is just a vasovagal response to anxiety and fear, which is the definition of syncope. Okay, so the question very clearly said that the patient is breathing normally. What would be your step of immediate management? So that was the question. The options were recline the chair, shout for help, and give supplemental oxygen. All of us have seen this in our oral surgery postings. This is what we usually do. We just stop the procedure, whatever, either we are giving LA or we are doing the elevation or luxation of tooth, whatever we are doing, we stop the procedure. We remove anything that is there in the oral cavity, remove or clear the oral cavity, any instruments, any cotton roll or anything which is there. Even if saliva is there, we try and suction it out. We make the patient supine with leg elevation. If we are untrained, if we are not capable of handling such a situation, we call for help. We call our seniors, we call our consultants, our whoever faculty is there, we call for help, and we give oxygen to the patient via mask, just by mask, or prongs if you have nasal prongs or attachment wire. It's just a superficial source of oxygen that we provide to the patient. You don't intubate the patient for such a simple thing, and most of these procedures are done immediately. Sometimes students ask me, man, Trendelenburg position. Yes, Trendelenburg position you can use, but Trendelenburg position basically 45-degree tilt of the legs, usually done for gynecological and such pelvic procedures. If that is an option in the question, you can mark Trendelenburg position. Usually a slight elevation of the legs suffices, because the purpose is to increase the venous return from the peripheral tissues towards the heart. Okay, so this is what we do in a syncope situation. Okay, and this exactly was our option A. So you mark the option A. Now option B, CPR with only chest compresses. The patient is breathing. The patient normally breathing. Okay, so his airway breathing circulation is usually okay. He might have reduced pulse rate. He might have, you can just check the pulse. If the pulse is slow or even bounding pulse which is less in rate, that means his heart is working fine. His heart is beating. So CPR is not a cardiac arrest, so you don't need to do. It was a confusing option because they have given CPR with only chest compression to confuse you, because the question says he is breathing. It is not mentioned whether his heart is working or not. But if it is he is breathing, usually in this situation his heart is working. So CPR with chest compression is not usually required. Prepare for intubation. It is too dramatic to do that, because usually if he is breathing normally, why would his airway collapse? And why would you want to intubate the patient? So this is wrong. And check BP pulse ECG is okay. You can do it, but it is not the first step of management. First step is you just try and manage what is wrong. So if you know the diagnosis of this unresponsiveness, which is a vasovagal syncope or a vasovagal response, the correct immediate treatment is the option A. Okay, you can check the BP pulse. ECG is usually not required, and based on that, if the patient is responding within 15 minutes, usually the patient responds in 1 to 2 minutes only. Okay, you can check the pulse, you can check the blood pressure. If the patient is a slow responder or not responding, you can give some, you can break an ampule of ammonia spirit and give, put it under the nose and do all those stuff. Usually it is not required. Usually you will see that the patient gains consciousness within 2 to 3 minutes only. Just stop the procedure and defer it for later on, or if you are confident, if you can take the patient under confidence, you can just handle the situation yourself. Okay. Next question. Typical question on general anesthesia. Daycare surgery can be undertaken with all these agents except. So first let me answer this question for you, and then let me explain you certain concepts of general anesthesia. What is a daycare surgery? A daycare surgery or an ambulatory surgery, just like the name suggests, it is any procedure where the admission, the surgery and the discharge, it is done within 24 hours, is called a day care surgery. Matlab in the same day, you are admitting the patient, you are performing the surgery under general anesthesia, and in the same day by the evening, you are discharging the patient. This is called ambulatory or a day care surgery. Usually, initially what used to happen is the effect of the drugs that we used to give for general anesthesia, that effect used to stay for a long time. Post-operative nausea, vomiting, muscle cramps, muscle twitchings. These are the complications of the general anesthetic drugs that used to be given earlier for surgeries. And for these GA complications, the GA drug effects, we used to keep the patient admitted for a longer time. Also because of the surgery, but also because of the GA drugs. With the advent of better techniques, with the advent of better drugs for induction and maintenance of general anesthesia, it is possible to perform day care surgeries, and it is always better to discharge the patient early, because hospital-acquired infections, hospital-acquired, psychological problems with the patient, that, oh, I am admitted, I am sick, such things do not happen. Hospital-acquired, ICU-acquired infections, ward-acquired infections are always less if you discharge the patient early. So day care surgery is possible because there are certain drugs whose post-operative effects wean off quickly, and they are good effects post-operatively. So, which of these agents which of these agents will not be used, except, is the question, and the answer here is halothane. Propofol is the most commonly used drug for day care surgery, and this is a multiple times repeat question, okay? Which is the most preferred agent for day care surgery? Propofol. So, TIVA, total IV anesthesia, propofol. I will explain what this is. Drug most commonly used for day care surgery, propofol. So propofol is definitely one of the drugs used for day care surgery. Sevoflurane, desflurane, isoflurane. They are also used as maintenance inhalation agents for day care surgeries. Halothane is, in general also, halothane is used very less in general anesthesia. It is a induction as well as a maintenance agent. It has good muscle relaxant properties, it has good analgesic properties, but it has severe myocardial depression, severe cardiac depressive properties, which is why it is not very commonly used nowadays. So halothane is the answer here. Now just let me in brief tell you about general anesthesia. Okay, we will discuss this in detail when we are doing our live class or the recorded sessions. When we take a patient for general anesthesia, what are the things that we give to the patient? First, we give pre-anesthetic medication. First thing that we do, that an anesthetist does, is give pre-anesthetic medication. Second thing that we do is induction. You induce anesthesia to the patient. And this is all going parallelly, okay? Sometimes there is an overlap. Then there is maintenance. There is muscle relaxation. Then there is reversal. And then there is, before muscle relaxant, and then there is analgesia. Analgesia and sedation. There is muscle relaxation and there is reversal. Okay? Pause here. Restart. Okay? So, in giving the patient general anesthesia, this is usually the order that we follow, and there is a good overlap between induction and muscle relaxation, between maintenance and muscle. Again and again you might have to give a muscle relaxant during induction also, during maintenance also. You have to give a reversal agent to reverse the muscle relaxant effect and all those things. So usually these things are overlapping so many times. Okay. In pre-anesthetic medication, you give the patient anticholinergic drugs and certain CNS depressants like midazolam and anticholinergic drugs like atropine and glycopyrrolate. These are the basic drugs. These are the most commonly used drugs. Of course, there are many more drugs that you can give to a patient for pre-anesthetic medication, but these are the few drugs that you have to know. Okay, you give the patient midaz, you give the patient atropine, glycopyrrolate, you also give the patient some antacids like ranitidine or pantoprazole. You also give the patient certain antibiotics. But this is for more for surgery. Usually for pre-anesthetic medication, these are the two main drugs that you give to the patient. Okay, and how do you give that to the patient? To the IV route. You have cannulated the patient, you put an IV cannula, and you give the patient through an IV route, midazolam, atropine and all that. Then you induce anesthesia. You give a IV induction agent by which for a short time, for a very small time, the patient will be under the anesthetic effect. And it is after the induction that you put the intubation tube, you put the endotracheal tube into the patient. If you try and put an endotracheal tube in an awake patient, he will not tolerate it. Only very rarely you can do a awake fiber optic intubation, but that is also under some induction, some sedation. But induction is done to induce a state of temporary loss of consciousness in the patient, and that is done with propofol. Most commonly it is done with propofol. It can also be done with etomidate and other drugs also. Okay, most commonly used agent for induction is propofol in daycare surgeries also. Okay, etomidate is usually used when we want hemodynamic stability. But propofol is the most commonly used drug for induction. Both these things are given IV. Okay. Then we come to maintenance. Now you have induced loss of consciousness in the patient. You have intubated the patient. Now you want, and propofol's effect lasts for a very short time. Okay, you have to keep giving propofol. To continue the effect of anesthesia, you give certain maintenance agents. Okay, what can you give for maintenance? You can give for propofol also, which has to be given IV again and again and again. Or you can give inhalation agents. You have intubated the patient, the tube is connected to the ventilator. What you can do is, that ventilator can mix oxygen with certain inhalation agents that will maintain the loss of consciousness in the patient. Okay, that will maintain anesthesia in the patient. These agents are sevoflurane, isoflurane, desflurane. Okay, these are good drugs. The reversal is fast and recovery is good. So these are good agents. So this is given via inhalation. Okay, this is the only thing which is given by inhalation. Everything else, if you notice, is IV. The preoperative pre-anesthetic medication is IV. The induction is IV. These are done IV. Maintenance, if it is done by propofol, it is IV. Only inhalation agents till now are through mask, through inhalation. Analgesia and sedation, it is a multimodal analgesia that we do in the patient. We use NSAIDs, we use opioids like fentanyl, morphine, fentanyl and remifentanil and alfentanil. These are the drugs we used for daycare also and for other proper longer surgeries also. Fentanyl, remifentanil and alfentanil. These are the drugs we use. Okay, NSAIDs, diclofenac, paracetamol. Usually we use paracetamol in the OT, but you can use other NSAIDs. And we give local anesthesia also at the site of surgery. So this is multimodal analgesia. So if you only give general anesthesia, then the pain is carried from the site of surgery to the brain. But the patient is not able to respond to that pain because he is anesthetized. So he is feeling the pain. It is just the motor response to the pain is not there, which is a very bad thing. You are giving pain to the patient by doing surgery, but you are not letting him respond to that pain because of anesthesia. And the post-operative effect of this is very bad. That is why multimodal anesthesia is given, that at every step, the pain should be blocked. So we give local anesthesia at the site of surgery, so the pain is blocked there. We give NSAIDs so that the pain reception is blocked at the cortical level, NSAIDs and opioids, and we give anesthetic so that the motor response is also lost. So LA, before the surgery also we give LA. We infiltrate lignocaine at the incision marking. After the surgery also we give LA. We give usually long acting LAs like bupivacaine, which has long acting effect, so that even after surgery the patient is devoid of pain from the site of surgery. So after surgery we give, but at the closure of the surgery, at the closure of incision, we give long acting LAs like bupivacaine. It is cardiotoxic, so you have to be very careful while giving bupivacaine. Okay, so analgesia and sedation, again these things are also given. Everything is given IV. LA of course we are giving at the site of surgery, but NSAIDs, opioids, again we are giving IV. Muscle relaxation is very important. Muscle relaxation is done mostly with succinylcholine. It is a short acting muscle relaxant. It is used during induction. And later you can use the curare drugs like mivacurium, rocuronium, okay, and such things, atracurium. So these drugs are the muscle relaxants. Okay, how do you give these drugs? IV. Okay, so just before induction, just before inducing the patient to sleep, you give a muscle relaxant. Mostly we give scoline. So the muscles are relaxed and intubation is easy. You can put the tube, the laryngeal muscles are relaxed, the suprahyoid muscles are relaxed. You can do a laryngoscopy properly. You can put your tube because there is no reflex action of the muscles to inhibit putting that tube. So muscle relaxation is also done during induction and during surgery. Of course, a surgeon will tell the anesthetist, okay, now I want less muscle relaxation because I want to check the effect of the muscle on my surgery and all those things. So muscle relaxation is also that we do during induction and throughout the surgery by a coordination between the surgeon and the anesthetist. And in the end, when everything is over, when the surgery is over, when you want to awake the patient, you do a reversal. Usually, you do a reversal of the muscle relaxation with reversal agents like pause. With reversal agents, start. You reverse your local anesthetic effect with reversal agents like neostigmine, glycopyrrolate. Okay, and basically neostigmine is your reversal agent, but during reversal you also give the patient glycopyrrolate and a new drug, sugammadex, and so many other things. Okay, we will discuss this in detail in our classes, but this is just the basic of, and how do you give these things again? You give them IV. Okay, so this is just the basic of what happens when you give the patient a general anesthesia. You give pre-anesthetic medication, you give induction to the patient. I don't know why this is coming black. You give maintenance of anesthesia. You give analgesia and sedation. you give muscle relaxant, you give reversal agent in the end. So you have to know the main drugs, their advantages, their disadvantages. Like propofol is a very good drug to prevent post-operative nausea, vomiting. You have to know the characteristic of these drugs that we will discuss in detail. Okay, and most of the things are given IV. So if you're not using your inhalation agents in surgery, then it is called total IV anesthesia or TIVA. Okay, if you're not using inhalation agents for maintenance and you're using all the other things, it is called total IV anesthesia or TIVA, and the drug of choice in TIVA is propofol. Okay, so this is how we give general anesthesia. And if you know just these things, just these drugs, just these things about general anesthesia, you will be able to answer most of the questions of general anesthesia. Coming to the next question. Which of these is the best tube for submental intubation? Tricky question. The answer is South Pole tube. Okay. To answer this question, you have to know the types of tubes. Okay. So a simple PVC tube, a simple plastic PVC tube is called an ivory tube. Okay. What is the advantage? It is cheap. The cost is less. What is the disadvantage? So if you put a tube, if you put this tube through the nose or through the mouth, okay, either nasotracheal intubation or orotracheal intubation, and you are performing an oral surgery. So this tube, if it comes in the way of surgery somehow, because one assistant is retracting, one operator is operating, another assistant is doing something, this tube can bend. And if it bends, it will kink. It will kink. Kink means it will bend and the flow of oxygen, the flow of gases will be reduced in this tube. So kinking is one of the disadvantages of a simple plain PVC tube or an ivory tube. So it is the conventional tube which were being used initially. Then came reinforced tubes. Reinforced endotracheal tubes. Why is it called reinforced? Because there are metal rings throughout the tube. There are metal rings throughout the tube. Okay, if you watch this image clearly, you will be able to see that there are metal rings in this tube. And because of the metal rings, it will never kink. Okay, the folding that is shown in this image is just to show that even it is twisted and turned and folded, it will fold, but it will not kink. The airflow or the flow of gases during surgery will never go down. Okay, so it will not kink. That is the advantage of a reinforced tube. Now, three people, Ring, Adair, Elvin. These are the three surgeons or three anesthetists. I don't know. There were some good, intelligent people. They said that if we give a definite shape to a tube, it will be away from the site of surgery. So they gave two shapes. They gave the North Pole tube and a South Pole tube. It is nothing but basically reinforced tube which is preformed. They are also called preformed tubes. Okay. So if I am doing a cleft lip surgery, so if I am doing a surgery on the cleft lip, okay, I cannot do a nasal intubation because for cleft lip surgery, I need the nose also to be free of the tubes and everything. So I will do an oral intubation. If I put this simple tube through the mouth, again and again it will keep coming in the site of surgery and it will be irritating for the surgeon that the tube is coming in the way of surgery again and again. So what I will do, I will put the tube. So if this is my oral cavity, I will like a tube which is going into the trachea like this. This is my reinforced tube, and rather than coming straight into the mouth, it is bent like this. It is bent towards the south, towards the leg of the patient. I will prefer a tube which is coming out like this so that my site of surgery is free of the tube. This is called a South Pole tube. So whenever you are doing an oral intubation, you can prefer a South Pole tube because it is away from the oral site and the nasal site, and it gives you good vision, good exposure, good visibility of the nasal and oral structures. Just like that, if you're doing a submental intubation, so usually when you do, either you can do a direct submental intubation or you can convert an oral intubation into a submental intubation. So in pan-facial fractures or in polytrauma situations, suppose I'm doing a pan-facial fracture in the trauma center and I want that I cannot have a nasal tube because I have to do fractures here in this region and I want to do my IMF also. So I can't to put a nasal tube, I can't put an oral tube because if I put an oral tube, I can't do my IMF. So in such situations, I need a submental intubation. So I put a submandibular incision, I do my dissection up to the floor of the mouth, and instead of the tube coming out through the oral cavity, I take my tube out from the submental region like this. Okay. Again, let me show you. If this is my patient, and this is the tube, I want my tube to come out south pole because that will make my surgery site clear, and instead of the mouth, I want it to come out from the submental region. So this is south pole tube submental intubation. It is the best way. If I put a simple ivory tube with so much bending, it will kink. If I put a reinforced tube, it will not kink, but it will come in my site again and again. It will be irritating. It is better if I put a south pole tube. If I put a north pole tube, I will not be able to put a north pole tube because that tube will come out like this and it will bother me again and again. Where will I use my north pole tube? North pole tube is when I do a nasal intubation and from there it goes up. It goes north. So this is my north facing north pole tube which goes up after intubation, and a south pole tube which goes down after intubation. Okay, so north pole tube is usually used after nasal intubation when I'm doing an oral surgery, a lip surgery, or whichever surgery and I want the oral cavity free. A south pole tube can be used from oral intubation or submental intubation. Okay, so this is the answer for this question. Best answer here is the south pole tube because north pole tube, if I do submental, it will come out like this and it will not solve the purpose of submental intubation. If I do ivory endotracheal tube, it will kink because there is a lot of bending that is involved in the submental intubation. If I do a reinforced endotracheal tube, it is okay, but it will again interfere with my oral cavity and fail the purpose of submental intubation. Okay, so the best answer is a south pole tube. Next, coming to the next question, the image shown below, it's a very easy question. All of us know that this is a rongeur forceps. How many of you have marked osteotomy? Many of you have marked osteotomy. You cannot do osteotomy with a rongeur forceps. You can do ostectomy. You can do ostectomy. Remove the bone. Osteotomy is a clean cut. Is a clean cut in the bone. It's a neat fracture that you create in the bone is what is osteotomy. Okay. So if this is your mandible, if you are putting a cut in the bone, it is called osteotomy. If this is your mandible and if you are removing this part of the alveolar bone and taking it out of the body, it is called ostectomy. Can you do an osteotomy with rongeur forceps? No. You can only do it with a burr, with a piezoelectric saw, or with an oscillating saw, with such devices. So osteotomy you cannot do with the rongeur forceps, and this was the trick that was used by the examiner in the question. Ostectomy, if ostectomy would have been asked in the option, in the question, definitely you can do ostectomy with the rongeur forceps. Whatever sharp ends of the alveolar bone is left after extraction, you cut those sharp ends with the rongeur forceps and take them out of the body. Osteotomy, on the other hand, is a clean, neat cut in the cortex of the bone. And that is done with a burr, with a piezoelectric device, with an oscillating saw. The options were arthrotomy, that is a joint procedure. Definitely you don't do it with a forceps. Sequestrectomy, which definitely you do with a Ronjo forceps. Okay, sequestrum is basically the dead bone which is lying in the site of osteomyelitis. Okay, this is what sequestrum is. Whenever there is an osteomyelitis or an infection of the bone, there is dead bone lying in the site of infection, and this dead bone needs to be removed. This dead bone is called sequestrum, and this dead bone needs to be removed, and that can be done with a Ronger forceps. So sequestrum or removal of the dead bone is done. Osteotomy you cannot do with a Ronger. Ostectomy, yes, ostectomy you can do with a Ronger. So this is the trick used by the examiner, and this is what is made wrong. Maxillary root removal, only if you are not seeing the image properly, you will confuse it for a bayonet forceps. I'm sure most of you have ruled out this option. Most of you know that this is not used for maxillary root removal. A bayonet forceps, which handle is like this, is usually used. This is the confusion that most of you must have faced. Sequestrectomy and ostectomy. Ostectomy, if it is asked, yes, it is the right option. Osteotomy, it is unfortunately the wrong option. Coming to the next question, straightforward, multiple times repeated. Which is the principle behind this instrument? It is a crossbar elevator. And the principle is wheel and axle. Okay, the principles behind every elevator we have discussed multiple times in the live class also. It is a very clear-cut, easy question. Third year onwards, we are reading about these instruments and there is nothing to discuss. Okay, this is a very clear-cut, easy question. Crossbar elevator, principle is wheel and axle. Next question. Okay, what is the diagnosis of the OPG shown in the image below? Okay, most of you must be confused between condylar hyperplasia and right mandibular hyperplasia. Okay, so basically it is a kind of a disorder of growth of the condyle. Okay, so if I just trace, the approach to these kind of questions is you have to trace the mandible. Okay, so if I trace my mandible outline, this is what you have to do in exam. If you can trace this virtually with your finger, obviously you don't have a marker and all in exam, but even if you're with your finger, if you can trace it, you will be able to answer this question. Right condylar hyperplasia. Yes, I can see that the right condyle is growing more than the left condyle. Right hemimandibular hyperplasia. So when I classify condylar hyperplasia, it is classified into hemimandibular elongation, hemimandibular hyperplasia, and a mixture of both of these. Okay, this is how I classify condylar hyperplasia. Okay, hemimandibular elongation means only the condyle is increasing in size and it is causing a shift of mandible towards the opposite side. Okay, the condyle is increasing in size and it is causing, because of the increase in length of the condyle, there is a shift of the remaining hemimandible to the other side. This is seen in hemimandibular elongation. In hemimandibular hyperplasia, there is a 3D enlargement of hemimandible up to the midline. Okay, in hemimandibular hyperplasia, the whole, what I would have seen is this what I would have seen is this whole mandible would have increased in size. This whole half mandible would be enlarged in size till half of mandible. So hemimandible hyperplasia is a 3D enlargement of the whole of the mandible of that side. Whereas a hemimandibular elongation or simply a condylar hyperplasia is just the condyle being enlarged, and that is what is seen in the OPG. So the left condylar hypoplasia, no, the left condyle looks normal to me. Left hand hemimandibular hypoplasia, no, the left mandible, whole mandible looks normal to me. So it is a right condylar hyperplasia because there is no 3D enlargement of the mandible, just the condyle of the mandible on the right side is what is enlarged as compared to the left side. So the answer is right condylar hyperplasia. Slightly difficult, but if you have read this, if you have done this in your classes, if you have seen this video in the recorded videos, you know the answer. Again, a very tricky question. Describe the type of fracture shown in the image below. Just tell me how many of you have marked horizontally favorable fracture. 90% students have marked horizontally favorable fracture. 90% of the students must have marked this, and it is a wrong answer. Why? So let us rule out each option, okay? If you know the definition of comminuted, if you know the definition of compound, if you know the meaning of vertically and horizontally favorable and unfavorable, you can answer it. Just by knowing the definition, you can answer it. What is vertically favorable, unfavorable? Vertically favorable, unfavorable is if I'm seeing the mandible from the top, from the vertical, in an occlusal view. If I have an occlusal view of mandible, from which I can see the fracture line, then the occlusal view is a vertical view. I'm vertically seeing the mandible, and then I can classify into vertically favorable or unfavorable. Now, what is favorable and unfavorable? If the direction of the fracture line is such that the muscle pull is reducing the fracture, then it is called a favorable fracture. If the muscle pull is displacing the fracture, it is called unfavorable. So this is vertically favorable or unfavorable, okay? Coming to horizontally favorable, when I am seeing the mandible from front, from horizontal, it is called a horizontal view, okay? So this definitely you can classify this into horizontally favorable and unfavorable. This is a horizontal view of the mandible, okay? So here you can classify it into horizontally favorable or unfavorable. Now this is the fracture line, okay? In exam, the fracture line was here. 8 was missing and the fracture line was here, which is communicating with 7, okay? Just for reference, I have put this, which is similar to the question asked in exam. Now, what is the direction of masseter muscle fibers? This is the direction of the fibers of masseter, okay? The masseter muscle is inserted into the angle of mandible, and this is the direction of pull of the masseter. This exactly is the direction of pull of the medial pterygoid. Agreed? Everybody agrees to this? The direction of pull of masseter and medial pterygoid is like this. So when the patient chews, when the patient brings his teeth into function, into dynamic occlusion, do you think that this fracture line will displace along with the masseter? Yes or no? Yes. Since the direction of the fracture is parallel to the direction of the pull of muscle, when this loading will happen, when the patient will chew, the suprahyoid and the other muscles in this region will pull this segment of fracture down, and the masseter and medial pterygoid will pull this segment of fracture up. So this segment goes down, this segment goes up, and it becomes an unfavorable fracture. Okay, just because it is a horizontal view, most of you have marked horizontally favorable fracture. It is not a favorable fracture. It is an unfavorable fracture because the direction of fracture line is parallel to the direction of the muscle fibers. And the muscle fibers will displace the proximal segment upward and it will displace the distal fragment downwards, which is called an unfavorable kind of fracture. If the direction of fracture would have been like this, okay, or let me put it more clinically relevant, if the direction of fracture would have been like this, okay, like this, then I would have called it a horizontally favorable fracture. Why? Because this is the direction of pull of the masseter, okay. When the masseter is in function, when the teeth are loaded and the masseter is in function, it is keeping this segment along with this segment. It is pulling the segments together. It is keeping the fracture reduced in its place. It is preventing the displacement of fracture fragments. So the direction of fracture line is opposite to the direction of pull of the muscle, the masseter and the medial pterygoid. So this is a horizontally favorable fracture. If the direction of the fracture would have been like this, then you could have marked a favorable fracture. But this question, the direction of fracture is like this. So the answer is compound fracture. Why? Is it a comminuted fracture? No, it is a single linear fracture which is not broken into many parts. If it would have been broken into many parts, you would have called it a comminuted fracture. It is not a comminuted fracture. Okay? What is a simple fracture and a compound fracture? A simple fracture is something which is not communicating with external environment. Okay? What is external environment? For the mandibular fracture, either it is skin or oral cavity. So if the fracture is communicating through an oral laceration to the oral cavity, it is not a simple fracture, it is a compound fracture. If a fracture is communicating, that if it is a laceration on the skin and the fracture is communicating through the skin laceration outside, it is called a compound fracture. This fracture is communicating to the oral cavity through the periodontal ligament of the third molar. This fracture is communicating with the oral cavity through the PDL of 8. This is a very commonly asked question in the wards. Usually when we are residents and we are attending the ward rounds, in most of the colleges, this is a commonly asked questions in the ward. What kind of a fracture is it? Is it a simple fracture or is it a compound fracture? Your decision of giving antibiotics will depend on whether it is a simple fracture. When can it be a simple fracture? If it is a fall which is causing a condylar fracture, here, it is not communicating intraorally, it is not communicating extraorally. There's just a hematoma there and there is a fracture in the condylar neck, then it is a simple fracture. There is no laceration, just a blunt injury which has caused condylar fracture. It is not communicating with the oral cavity, it is not communicating externally. Then it can be a simple fracture. But this fracture here, it is communicating with the oral cavity through that communication with the periodontal ligament of the tooth. That is why it is a compound fracture. That is why it is a compound fracture. So the answer to this question is compound fracture. Okay, vertically unfavorable, most of you have ruled out. The correct answer is compound fracture. Next question, multiple times repeated. The blade shown in the image is used for, it is an 11 number blade. It is used for stab incisions, like for incision and drainage. like for cricothyroidotomy, just a skin stab needs to be given, and then you do your dissection through that. So for stab incisions, you use a stab blade like a 11 number blade. For conventional submandibular incision, you use a 15 number blade. Preauricular and clavicular incision, you use a 15 number A, B, C blade. So for stab incisions, like for incision and drainage, for cricothyroidotomy is an emergency procedure where you put an incision in the cricothyroid membrane and you put your airway through it. So for that, you use a 11 number blade. It is a very commonly asked question, very repeated question. Next, again, this is a repeated concept which has been asked again and again in exam. A 2-year-old child has fall from bed. On examination, there is no clinically palpable fracture, but the child is crying a lot and refusing to feed. This is all signs of condylar fracture. Condylar fracture, usually you cannot feel a step in the joint. There is pain to the patient because of which he is crying, because of which he is refusing to feed. Since it's a 2-year-old child, he cannot pinpoint the region of pain. And which of these is the treatment modalities will you choose? So for condylar fractures, for articular fractures, that is fractures inside the joint cavity, for condylar head fractures, for condylar neck fractures, in such a small child, the only treatment that you give is you allow condylar remodeling. You allow condylar remodeling because the growth and the reparative ability of this 2-year-old child is very high. The condyle can very well remodel into its shape and you don't need a really fixation. But a very important thing that needs to be prevented is TMJ ankylosis, because in high condylar fractures and condylar neck fractures, there is bleeding into the region and this blood can organize and form a bony ankylotic mass. So TMJ ankylosis is very common in young children with condylar fractures. So to prevent TMJ ankylosis, the treatment of choice is aggressive mouth opening exercise. Now you will argue that in case of fracture, why will you do mouth opening exercises? Don't worry. That is the treatment you have to do along with painkillers and everything that you will support the child with. But you have to give him mouth opening exercises because the fracture will heal. Because of the young age of the child, the fracture will heal, the condyle will remodel normally and it will grow normally. But the only approach to this patient is to prevent ankylosis by aggressive mouth opening exercise. If you avoid hard food for 2 weeks, you will reduce the amount of exercise that the TMJ has to do and it will be a wrong approach. I'm up for 15 days is not required because the condyle will remodel. Hot fermentation in the area of pain, there is only some swelling will reduce. There is no role in treatment. Okay, so the treatment is aggressive mouth opening exercises to prevent TMJ ankylosis in this patient. The condyle will remodel, the fracture will heal in this patient anyhow. Okay, this is a difficult question. Which of these will be a sign of anterior disc displacement in an adolescent? I didn't really understand what the examiner is wanting to ask by asking in an adolescent. Very commonly, we see internal derangements in adolescents, especially during their board exams, especially when they're preparing for an entrance exam, when the stress level is very high. In these situations, very commonly, even in my postings as a resident, as a senior resident and as a senior research associate in AIIMS, very commonly there were adolescents, children from 17, 18, 19 years of age, where the stress levels were very high, examination pressure was very high, oral ulcers, disc derangements were very high in adolescents. But which of these will be a sign of anterior disc displacement? I don't know why the examiner is asking this correlation, but options are very clear-cut. Absence of pain, no, there will be pain whenever there is an early disc displacement. In later stages, there will be absence of pain. But considering a general situation, there will be pain. Reduced mouth opening, yes, this will always be a sign of internal anterior disc displacement till the time it is so much chronic that the disc is resorbed. But in most of the situations, there will be reduced mouth opening. Deviation of jaw in eccentric movement. In normal opening only there will be deviation of jaw. So this is not a very appropriate option. And absence of pain on loading of teeth. This is absolutely wrong because pain happens usually when there is chewing, when there is loading, when there is mouth opening. So the best option in this question is reduced mouth opening. So basically, if I just have to explain you this concept, this is your mandibular condyle, this is your glenoid fossa, this is your articular eminence, and this is your temporomandibular joint. In the temporomandibular joint, this is your articular disc. Okay. So when you open the mouth, the condyle moves ahead and the disc moves ahead along with the condyle. In the anterior disc displacement, instead of the condyle and the disc moving together, what happens is this disc comes ahead. This is connected to the lateral pterygoid. This disc comes ahead of the joint and there is clicking or plopping noise. When there is plop, the disc comes, when the patient is opening the mouth, the disc slips in front of the condyle and blocks the translation of condyle. And the retrodiscal tissue is stretched and it is coming in articulation. So the retrodiscal tissue stretching and coming into articulation is causing pain. The abnormal anatomy here is causing pain. And the disc coming anterior to its normal position, anterior disc displacement, is causing a hindrance in the path of translation of the condyle. So this causes the reduced mouth opening. When we discuss internal derangements of the temporomandibular joint in the live class, we discuss this very detailed. For now, just understand that an anterior disc displacement is the disc which is lying in front of the condyle. It can be with reduction or without reduction. Whatever it is, there will be a reduced mouth opening. Okay, so that is the best answer for this question. Similar question, consider the following options: early opening and early closing click, pain, reduced mouth opening, pain disappearing on loading, deviation of opening. Which of these will be findings of early disc displacement with reduction? So clicking is usually gone in the later stages. So I will see clicking in the early stages. I will see pain in the early stages. I will definitely see reduced mouth opening. I will see deviation on opening because the deviation can correct, the deviation cannot correct, depending on which stage it is. So in early stages, there will be deviation with correction. So findings of A, B, C and E I will find, and this is the correct option. Next question, again a straightforward repeat question. Identify the wiring which is shown in the image below. You can see eyelets being made, and eyelet is the correct answer. It is an IV eyelet wiring where such eyelets are made before inserting into the patient, and then the eyelets are fixed with wires. I mean, a single wire is taken and you twist and form loops, and this kind of an eyelet is made, and the two wires of the eyelet are twisted around the teeth and they are tightened. Okay, Gilmer wiring and direct wiring is the same thing. You put few wires on the upper teeth, you put few wires on the lower teeth and you tie them together. This is called Gilmer or direct wiring. It's a kind of IMF, temporary IMF that you can do. And Risdon wiring is, this is not Risdon wiring. Risdon wiring is when you take each tooth together, you put wire around each tooth and you tie all the wires together. It is a kind of splint wiring. And Gilmer is a type of temporary IMF kind of a wiring. Temporary intermaxillary fixation that you can do, and direct wiring is same as Gilmer wiring. Okay, so this image, what is asked in the exam, it is of IV eyelet wiring. Okay, next, which is the technique which is shown in the image, and this exact image from the textbook is picked up and it is given to you. This is the William Kelsey Fry lingual split technique. I'm sure most of you have marked this correctly. The lingual bone is being split here, and the tooth is delivered through the lingual path. Okay, so this is Kelsey Fry lingual split technique. It is, all these techniques are not really techniques. The buccal guttering technique is one which is used Often the buccal guttering technique, you make a gutter here, you make a bony gutter here, and through that gutter you can split the tooth and take the tooth out, or you can just elevate the tooth like that. It is not a buccal technique. Keen's intraoral approach is something else. It is a zygoma fracture reduction approach. It is not obvigisa technique. It is Sir William Kelsey Fry lingual split technique. Multiple times repeat. Image is not usually asked. Image was asked this time. Okay. A slightly difficult question. There was this image with the kind of a shadowing of this region. There was shadowing of this region and mark was there in this region. And the question was, the image below describes which principle? Basically, this is a distraction which is being done. It is a distraction osteogenesis. And specifically, if you ask me which kind of distraction it is basically a transport disc distraction. Okay. I am creating, so basically, if this is my mandible, one of the options was also gap arthroplasty. One of the options was gap arthroplasty also. Okay. So if I have a TMJ ankylosis, if this much of my TMJ is lost and it has formed bone because of ankylosis, okay, my surgery of ankylosis will be, I will remove this chunk of bone and I will have this kind of defect with me. Okay, I will have my glenoid fossa and I will have this much of remaining ramus of bone. Okay, ramus of mandible. What I do, I put this reverse L kind of a cut. I make this my transport segment or transport disc. Then I put my distractor device just like this device, one part of device into the transport segment, one part of device into the fixed bony segment, and it is connected and the keyhole is coming out externally. I turn this keyhole at the rate of 1 mm per day, which is the rate of distraction. Okay, and what happens is this distraction segment moves up slowly. Okay, so slowly, what will happen is this segment will go up. This segment of bone which I have created, which I have cut by osteotomy, I have created an a reverse L-shaped osteotomy, and I am taking this segment of bone with me up. Slowly I am taking up. And what is happening in this area? In this area, a new bone is being formed from the bony callus. New bone is being formed from the callus. This is the principle of distraction osteogenesis. Okay, you distract this bone upward, and at the right stage, at the callus stage of fracture healing, at the callus stage of bony healing, I distract my segment of bone, and from the callus, I generate new bone. There is osteogenesis. I generate new bone. And this is called distraction osteogenesis. And this was described by Gavril Elizarov. The orthopedic surgeon who gave this procedure first was Dr. Gavril Elizarov, and that is why it is called Elizarov's principle. The procedure that I am doing here is transport disc distraction osteogenesis, or TDDO. Okay, and the principle is Elizarov's principle. Honestly speaking, this is a repeat question. This distractor diagram is repeated before in INI and NEET. This Elizarov's principle is repeated before in INI and NEET. Identify this device is asked before in INI and NEET. TDDO as one of the options is asked before in INI NEET. So basically this is a repeat question. It is just that a repeat question doesn't mean that you just have to know the question and mug up the answer. Repeat question means you have to understand the whole concept behind that question, and that concept will be repeated in exam. Okay, so 60% of the paper was repeat questions, either direct repeats or such kind of concept repeats. The correct answer here is Elizaro's principle. Surgery first approach for orthognathic surgery can be used in all except. See, most of you have guessed this answer correctly, that it is skeletal class 2 malocclusion with TMD. Now first let me tell you what is surgery first approach. When we perform orthognathic surgery, the first step is doing pre-surgical orthodontics. Why do we do pre-surgical orthodontics? We do it because when the jaw is grossly decompensated, when the jaw is abnormally placed, when there is a skeletal malocclusion, what happens to the teeth is they try and compensate that situation by proclination or retroclination. Okay, so suppose it is a cleft palate patient. In a cleft palate patient, after the cleft palate surgery, the maxilla is unable to grow properly. Okay, so there will be maxillary constriction, there will be collapsed arch, there will be class 3 kind of a skeletal profile because of maxillary hypoplasia. Okay, so if I want to do orthognathic surgery, first I will see that because of the maxillary hypoplasia, the maxilla is unable to grow, the arch is collapsed. First, I need to align my teeth. I need to expand my arch. I need to align my teeth. I need to correct the retroclination or the proclination which is there. And after my surgery, the teeth should come in proper class 1 relationship, in class 1 molar relationship, so that the stability of my surgery is enhanced with the occlusal, with the correct occlusal relationship. If I perform my surgery first and the teeth are out of occlusion, grossly out of occlusion, then my bony surgery can also fail. My bony surgery can also relapse because the teeth are not in occlusion. And whatever bony procedure I have done, the teeth would want to go back to its normal position. So the first step in any gross abnormality is pre-surgical orthodontics. And then you do the orthognathic surgery, that is the skeletal correction, the bony correction. And last, in the end, you will do orthodontic settling. Means the minor corrections after the surgery, whatever the minor 1 to 2 mm changes, the final settling of occlusion is done after surgery. What happens in this method is the pre-surgical orthodontics takes around 1 to 2 years. And if the patient is going to a government hospital, there is a 3 to 4 years waiting also. That is irrelevant. There is a 1 to 2 year long pre-surgical phase. Then there is surgery. And there is again a 4 to 5 or a 2 to 6 months of settling phase. So all in all, the whole procedure becomes very long. So in some cases, when the discrepancy, when the dental discrepancy is very minimal, you can do a surgery first approach. Means you can skip this step. You can skip the pre-surgical orthodontic step and directly you can go for an orthognathic surgery followed by an orthodontic settling. And out of common sense, you know that this can happen only when the dental deformity is mild. Only when the dental deformity is mild, you can go for a surgery first approach. So what are the indications for surgery first approach? There are very strict indications. Not all the cases can go for a surgery first approach. The strict indications are well-aligned arch with mild crowding. Arches with mild crowding. Okay, that means the maxillary and the mandibular alveolar ridges are well aligned with each other, and only slight crowding is there that you can settle after the orthognathic surgery. And you can just, like, suppose you are doing a segmental surgery for open bite, the rest of the teeth are aligned. You can avoid a pre-surgical orthodontic in such cases. You can just do the segmental surgery and settling can be done later on. So well aligned arches with mild crowding, you can go for a surgery first approach. Second is a flat to mild curve of spee. Even if the arches are aligned, but there is a very severe curve of spee, or if there is a reverse curve of spee, then you definitely have to go for a pre-surgical orthodontics to correct the curve of spee first, and only then you can do your orthognathic surgery. Otherwise, your surgery will be unstable and it will relapse. Only when there is a flat curve of spee or a very mild curve of spee, you can go for a surgery first approach. The third indication is normal to mild inclination of teeth, of incisors. Inclination means it can be proclination or retroclination. Means there is only slight anterior inclination or a retroclination, very mild, that can be settled after surgery, that will not compromise the stability of the arch. When it is only normal to mild, in such cases, you can go for a surgery first approach and do an orthodontic settling later on. And the fourth indication is a minimal transverse discrepancy. Minimal means that you can correct by tooth movement. It does not need a bony movement. Okay, when there is a minimal transverse discrepancy, if there is a severe transverse discrepancy, then the first step is expansion of the arch. In an unexpanded arch, if you do an oral orthognathic surgery, it will definitely, one of the most unstable surgery, expansion is one of the most unstable surgeries that you perform. So if it is a very minimal transverse discrepancy that you can correct with post-surgical orthodontics by only tooth movement, then you can go for a surgery first approach. Okay, and the last is when for orthodontics only you need a decompensation surgery. Means the orthodontics cannot be performed without the surgery. Only in such cases you have to do the orthognathic surgery first. Okay, so these are the indications for surgery first approach of orthognathic surgery. So in this question, the options were mild curve of spee, which is the indication, mild anterior crowding, which is the indication, and some crowding of anteriors with mild teeth proclination, it is also correct. Class 2 skeletal malocclusion, which is a very severe kind of which is causing a TMD, which is also causing a temporomandibular disorder. So first you have to settle the occlusion. And in skeletal class 2, definitely there is severe retroclination or proclination depending on whether it is Div 1 or Div 2. So in these cases, you cannot go for surgery first approach. Okay. So this completes our recall for the oral surgery and anesthesia questions of May INICET 2023. You can leave your comments on the comment box. If there is any doubt, I will try and answer. I will try and clear your doubt through the comments in the comment box. Please leave your comments. I'm seeing there are certain comments coming up. Let me finish this session and let me get back to you on these comments. I will try and answer each and every questions of yours based on these topics. And if you really like it, like the session, you can join our live sessions, you can join our recorded sessions, and you will definitely benefit by the concepts that are taught to you during these sessions. And in these concepts, you will have an understanding of the subject that will help you answer the questions in the upcoming NEET and INI. I wish you all the best. And put on your comments whatever you have, your doubts or your likings, your dislikings, whatever things you want to discuss, please put in your comments, and I will see you again in the next live session soon. This is me signing off. Happy learning to all of you. Do well, and may God bless you, all of you.